substance use treatment and program manager for the health department. And while we cover both Granville and Vance, I am focused primarily on Granville. I help to facilitate the advisory committee. Next slide. So just as way of background, I don't know how much you all know about the settlement, which began frankly back in 2018. The state received close to 1.4 billion, 1.5 billion dollars for reparations regarding opioids. The vast majority of that goes out to the communities, which is terrific. Next slide. So the overarching goal of this settlement is to reduce and prevent opioid overdoses. Next slide. So as part of this arrangement, the County of Granville has entered into a statewide agreement, and we are stipulated to follow specific regulations from the MOA, this Memorandum of Agreement. One is that the county has created a separate fund for a little more than $7 million that the county will be receiving over the course of 18 years. So our final payment will be in fiscal year 39, and I'll be showing you a slide. It might even be in the next one that shows where the money's coming, when it's coming, etc. We have essentially two options of types of strategies: option A and option B, all evidence-based, but we are limited to those strategies. We just can't make things up and apply the money the way we feel we want to. We have to be very deliberate in how we use the funds, and we're required to submit an authorized spending resolution to the county board, which approves the spending of the funds. Each year, I'm required to do an annual meeting. Last year, what I tried to do, which wasn't too successful, is to do several community forums to update people about the work of the committee and to get input. Not too many people showed up for those meetings. So what I'm going to do this year is to do a virtual meeting that will just publicize widely so that everybody knows about it. And whoever wants to participate can. Okay, we'll go to the next slide. All right, so this will show you how the money comes in over each year. So it's not all one lump sum, and we don't get the amount of money at the beginning of the fiscal year. That's the amount of money that we will have by the end of that fiscal year. So we're in fiscal year 26 right now. So by June 30th of this year, we will have received $570,000, and we've received everything else prior to that up to now. Okay, next slide. So just to give you what's gone on before now, there was a lot of preparation around how to use this money, understanding the rules and regulations around it. The North Carolina Association of County Commissioners was responsible for helping to do that technical assistance training to county commissioners and county administration as to how we go about administering these funds. As I explained, we've got two types of strategies. The first strategy in option A really focuses on the abatement and support of opioid recovery. Option B is a little bit more involved. We're required to do a strategic plan to operationalize any of those strategies. But that's where you'll find some prevention strategies along with some deeper abatement type strategies. Okay, next slide, please. So for option A, these are the first six: collaborative strategic planning, evidence-based addiction treatment, recovery support services, recovery housing support, employment-related services, early intervention programs. Right now, we are funding collaborative strategic planning, which basically funds my position. And we've got other strategies in the next slide. So get to the next slide, please. So naloxone distribution, we are currently funding post-overdose response teams. We're currently funding syringe service programs, criminal justice diversion programs, addiction treatment for incarcerated persons we're currently funding, and reentry programs. We're funding, but that really hasn't started yet. So I'll talk about that. Next slide. Well, before I move on, any questions about those option A strategies?
What would you find the most important? What would you classify as the most important out of all those strategies? Would it be prevention? Would it be addiction?
Prevention. No, prevention. I think if we really want to do something about reducing opioid overdoses, we need to get to the root cause, and that's addressing prevention. It's important that we have support services to help people get into treatment and stay into treatment. So that's critically important. But I do believe that prevention is something that we really need to address. And hopefully we will in short order. So yeah, sir.
I was just wondering, is drug treatment court part of any strategy for these monies? Because, you know, we used to have a lot of drug treatment courts, and you could really work with people that were getting into criminal trouble. If they had they have to appear in front of a judge, have to be drug tested, and if they fell through the cracks, there were consequences. And that was something that was cut by our legislature over the last several years, treatment courts.
Yeah.
And they work very well.
So Trey, can you go back to the previous slide? So criminal justice diversion programs could possibly fall under that. And I think that's something that we are taking a look at. We've been focusing on this addiction treatment for incarcerated persons and then reentry. But now we need to also think about that pre-arrest, right? Rather than jail, which is not where folks belong when they have a mental health or substance use disorder, right? We want to get them into treatment. So I do think that will be a strategy that we'll be looking into. Whether it follows the same structure as a drug court, I don't know. I don't know. There is another strategy that's called LEAD, Law Enforcement Assisted Diversion. And that is something that we're taking a look at in terms of working with folks so they don't end up going to the detention center. But obviously.
Well, let me just plant a seed for you.
Yeah.
Half of my clients have drug problems.
Yeah.
I got 400 in some cases. So pre-criminal charges, you may be missing the boat.
Well, I want to have a conversation with you about that too, because on our, we have a different initiative, not part of the opioid settlement, called Stepping Up, which is a regional program. Have you heard of it, Commissioner? Stepping Up? Okay. It's a regional initiative focusing on mental health and substance use of justice involved. And so that too may be another place where we can address this, you know, pre-incarceration, post-arrest, but pre-incarceration, right? So we will have a conversation. Okay, Jay, next. So these are the unique strategies in B that are not found in A. I don't know why the state duplicated what they did. Prevent misuse of opioids is, I think, getting into the prevention piece is one that I am most interested in pursuing. Also, we're collecting data on around the prescribing practices of providers in Granville County. So that may be something that we can address as well. So anything we do really needs to be data driven. And so we're in the process of collecting a lot of data right now to determine next steps. Okay. So keep moving forward here. We've got our advisory committee that's formed, which is blessed by the Board of County Commissioners. The people who serve on the advisory committee serve for a 2-year term. In 2023, before I got here, I was hired in 2024. I'm that green box. In the blue box, the health department and county administration worked with the North Carolina Association of County Commissioners to do community outreach, to get people's input. And I believe there were 3 meetings, one here in Oxford, one in Creedmoor, and maybe one in Butner as well. In 2024, the committee had decided to approve the proposals from the sheriff's office to do that incarceration strategy, as well as Granville Health Systems to do the post-overdose response team. And then collaborative strategic planning was approved to bring me on board. Next slide. So the advisory committee is made up of a wide range of stakeholders. The meetings are open, even though we don't provide a virtual option, which I think is a little frustrating from my perspective. We do meet at the Expo Center monthly from 10 to 11:30 on the 4th Thursday of the month. And we do encourage open dialogue. But the 19 members who are voted in by the board are those who have the voting privileges for the committee, but we certainly invite comments and discussion from anyone and everyone. Next slide. So one of the first things that I did when I came to the committee 2 years ago is I wanted to be sure we were all on the same page. So we did create this vision and mission statement. So our vision is to be a thriving, unified community where every member has access to the resources, education, and support needed to prevent and overcome substance use challenges while fostering a healthier, more resilient future for all. Our mission is to combat the opioid crisis in Granville County by using evidence-based strategies to increase access to care, support recovery, and raise public awareness. Through collaboration with healthcare providers and communities, we aim to empower individuals to overcome addiction and build a healthier, more resilient society. So hopefully you can all agree with those mission and vision statements. Next slide, please. So collaborative strategic planning, what does that entail? Besides paying for my salary, et cetera, I help to facilitate the opioid advisory committee. I'm doing a lot of the data collection. I keep abreast of resources that are available to the county through our state partners and other regional partners. And I make sure that those strategies that we are funded are doing the things that they said they would be doing. They have specific tasks that they are to accomplish, so I try to stay on top of that. I provide the reporting, submit the reporting each year, and make sure that all the T's are crossed and I's are dotted when it comes to the settlement fund. Next slide. For Granville Health Systems, so the post-overdose response team, or PORT, is meant to be a bridge, if you will. The PORT team will go out after a 911 call. When EMS is dealing with an overdose, the community paramedics will visit that individual the next day and connect them to check in to see, would you like to start on buprenorphine? Would you like to start treatment? What kind of services do you need? Are you in need of, when was the last time you saw a doctor? I mean, that type of thing. So to really try to bring people together to the services they need. They will continue to visit that individual every day for 7 days. And then the hope is that that person is interested in treatment with one of our local outpatient facilities. We can also connect them to inpatient services as well. Peer support is to be provided. That person hasn't been hired yet, but technically speaking, that will be a continual relationship with the port for up to 6 months, just to check in to see how that individual is doing. Are there other services that are needed that are going unaddressed? That type of thing. Any questions about port or post overdose response team? Okay, next slide. So the Granville Jail, you may know that the jail has been providing medication for opioid use disorder for those who've been arrested and who had already started treatment. So the sheriff wanted to be sure people were able to continue treatment if they had already started it. What wasn't there until this grant was the induction service. So for those that had not started treatment, we give them the option, if they choose, because we don't force anything on anybody, to start treatment. And they have a choice of methadone or Suboxone. They also get counseling while they're in jail. And we have an LCAS, a licensed clinical addiction specialist, who's actually contracted from Vance Recovery to do an in-depth assessment. What's really exciting about this model, and I do think this will be a prototype for jails across the country, quite frankly, is the nurse that we're waiting to get hired through Southern Health Partners, who is the medical jail provider, will be doing an assessment of everyone who gets booked. Everyone who's arrested will be assessed for mental health and substance use. Now, the thing, as you may know, about jails is about 70% of the people bond out, right, within 3 days. The induction program would not start until day 3. And hopefully, you know, we can even make a difference with someone, even if they're in jail, and we've started them on induction even for a day, because we've started them on treatment. We want to see them continue on treatment. The port, we're hoping to connect to those individuals that bond out, because there's a whole population that's going unserved by not staying at the jail. So we're going to connect those 70% with the port, and that will be a function of the MOUD nurse that we hope it gets hired soon. Part of this too is to create person-centered plans. So the minute someone gets booked, we're also starting reentry, right? We want to start a plan to help that person get reassimilated back into the community, finding a job, getting those identifications reinstated, all of those little things that need to happen. That would be part of the reentry process. We're also starting a overdose prevention education series, if you will. Each detainee receives a tablet. And in order to access any of the classes that they can take or courses they can take on the tablet, they first have to watch the opioid prevention video. So they learn how to use naloxone. They know what they can do to prevent overdoses for themselves. We also tell them that don't use the same amount that you were using before you got arrested, because you are 50 times more likely to die within the first 2 weeks of being readmitted into the community if you've been using substances, because their body now has dropped its tolerance, right? So if they think that they can use the same amount, they're putting themselves at risk. Next slide. And this slide just shows you that about 50% of the detainees, when this data was taken, and it's pretty true today as well, have some sort of a substance use issue. So there's justification for doing this program. Next slide. So here's what we have for Granville County. We've seen a very slow increase in the number of overdoses in Granville County. 2025, it was nice to see the number go down. Now, I want to remind you, this is reported overdoses, so the actual number is a lot higher. But we want to continue to see that number go down. And so this is one of the things that methodologies we're using to track our success or effectiveness, if you will. Next slide. So where are we and where most recently, we did another round of proposals. We funded the North Carolina Harm Reduction Coalition for a syringe service program. And we also funded a reentry service program. Next slide. So, but however, come November, our syringe service program, county commissioners got cold feet and rescinded that, turned that into a naloxone distribution only strategy. But they also approved two other naloxone strategies. One is with Blue Cross Blue Shield that I'm hoping will happen. This would be for an outdoor dispenser that we're planning on putting outside the Department of Adult Corrections. So it will be available any time of year for anybody to help themselves. My hope is that will also include wound care, and it will be free, obviously. The other Narcan dispensers, and I'll have a slide to show you what we have available, are indoor dispensers that we are making available throughout the county. So the idea is if we can make naloxone, which is that reversal chemical that brings someone back from an opioid overdose, and it only works on opioids, then we can save lives. And that's the whole point of this, is saving lives. Next slide. So here are some of the dispensers that we have available. That first one box is not so much a dispenser as much as a training tool, but the next dispenser is a wall mounted that comes in various sizes. And then maybe something that you might want to consider for City Hall. The purple stand-up box, if you will, it's called the Barney. I just put one of those in at a church, Vernon Hill Baptist Church, this past weekend, and a larger one is going to go in the lobby of the jail. Granville Advanced Public Health just bought the purple and white wall mounted, that's gravity fed, and that's providing naloxone only. And then next to that is more or less the same thing. The Necessity Oasis provides other kinds of boxes that would include test strips or wound care, whatever you may want. But so these we're making available to organizations, businesses throughout the county. So if the city would want one of these, we're happy to accommodate that. And this is all free. I'm the one that does the ordering. I provide you with the naloxone. You just need to put it up. Yes.
How do people get access to it though? I mean,
Easy to open. They're not
there's
locked.
no lock on
They're
there.
not locked.
There's no code or anything you
Nope.
have to put in.
Nope. We really want to make it easy for people to help themselves. Right.
I'm just wondering whether that system could be abused, maybe. I'm not sure. I don't know.
Naloxone, you can't hurt anybody by naloxone. And I suppose, people could hoard it, but hopefully
yeah,
that won't happen. We do have QR code stickers on these because we are to make an attempt to find out age, gender, and home zip code of people who are taking the naloxone. So whether they do that or not is another thing, but we have to make the effort. Next slide.
Real quick, how
Yeah.
long do they have to take it after they overdose?
So the naloxone generally has a 2 to 3 year expiration, so it's right on the box.
But so if somebody's overdosing, how long do you have to give them that?
Oh, I see what you're saying. So the naloxone, depending upon how much drug is in their system, the naloxone will take about a minute or two to actually get into their system. It'll last, depending upon how much drug, up to 90 minutes or less. It is possible for someone to re-overdose even after they've had naloxone. Again, depending upon how much drug is in their system. Each box contains 2 doses, typically 4 milligrams. So these are the nasal spray variety, which is a lot easier. And I provide training on how you administer that. That information is also in the back of every box of naloxone. And most of these dispensers also come with a poster that describes how you administer it as well. Yeah.
Okay.
Otherwise, they're gonna have to not sit there and.
Gotcha.
Dr. Morse.
I heard you name a few places where you have them. What about within the city of Oxford?
Yeah, not yet. We're working on that. I have traveled around to a couple of places because a lot of people have see a doctor or some sort of healthcare provider before they overdose. That's what research shows. I have gone to the urgent care centers and the various primary care centers, mental health center, just to see if this is something they would like, left information. So,
Now, I'm just wondering, a lot of people who are addicts within the city are in walking distance to our fire department, walking distance to CVS, Walgreens. Have any of those areas been maybe an option
So
outside of these?
so all the first responders, fire department, police, EMS, they all have naloxone. We chose the location at the Adult Corrections Center, their department, which is right across from Thornton Library, because we know that there are individuals who use drugs who hang out under the gazebo there. We certainly would make naloxone available to anybody, who wants a dispenser. So, we will definitely make the rounds. So we're just getting going with this, and we anybody who wants it can have one. So yeah. So this is just a sample of what an a monthly financial report looks like. So we list the actual strategies, how much has been received, and how much has gone out. So in September of last year, we had received to date 2.6 million, and we had only spent a little more than 231,000 of that. So we're very transparent, make sure everybody knows what's come in and what has gone out. Next slide. Any questions about the financial piece? Okay. So where we are now is collecting data. And so we can determine next steps. And we're waiting. It's taken a while for some of the strategies that had been funded when I first arrived 2 years ago. Believe it or not, the MOED program is not quite launched yet, and the port still is missing personnel that we had hoped to be on board by now. So, things happen, but we're getting there. It is a slow process, much slower than I had hoped. We had done a fairly extensive amount of education around harm reduction last year, articles in the paper, lots of social media to help people understand that providing naloxone is not enabling someone to use drugs. It's all about saving a life. So this is pretty much where we are, and it's going to be a while, I think, before we will be implementing further strategies. It's a process just to collect all the data. My hope is that during the months of April and May, I'll be interviewing several people who are in treatment or in recovery to learn from them. How did they start? How did this disorder start with them? What resources are missing in the community that would be helpful? And then what are your ideas for prevention? How would you prevent someone from using? So that's really important that we hear from people with lived experience so that we can learn from their experience. Next slide. So we the state is making some progress. We're still not pre-pandemic in terms of the suspected overdose deaths. The death data always lags behind a little bit. So even the 2025 is still preliminary, but we are making progress, I think, in the right direction. Next slide. All right. that's it. So any questions about anything? Yes.
Always got questions.
That's
I
okay,
mean,
Commissioner. That's fine.
I think you're right. I think if you can prevent it in the first place, that would save
Yeah.
a lot of trouble. My question would be, do you find that opioids are overprescribed by many doctors? And if so, what is the reason for that?
Well, a lot of improvement has happened. So we're about to collect that data, so I can't tell you definitively in terms of Granville County, but I can say we now have a prescription monitoring system that's in place for all doctors to use, and Dr. Morse might want to speak a little bit more to this.
I mean, what we're seeing is not prescription opioids. It's all
Right.
So it's all coming in from China through the drug cartel in Mexico and flown over.
You're thinking like fentanyl or something like that.
So none of this is medicinal. It's
None of
not
it is.
that.
So it's not the stuff that you get prescribed oxycodone or something like that.
That's not what we're seeing.
Not anymore. At one point, that was indeed the case, where you had your
Well, I mean, I've
Oxycontin.
heard the stories about.
Yeah.
The Stop Act really stopped a lot
Right.
of the opioid rap. And that was like 5-6 years ago. So we saw a huge decrease in opioid prescribing after the Stop Act.
But because of the monitoring system now, doctors are, I believe, required
Yes, that was part of the Stop Act.
to then register, and then anytime they're prescribing gets inputted in there, and to whom. So people can't doctor shop and go from
Oh,
doctor
right.
to doctor, right?
Now, I know that there's been I don't know if it's a big thing now. I know at one point in time it was a big thing amongst the youth to take their parents or their grandparents' leftover prescriptions and have these what they would call Skittles party, where they put them all in a bowl and and they take these pills. What are we doing to educate these parents and these grandparents on what to do with leftover prescriptions? Because like in my household, we're having a wife who's epileptic and my daughter's has CP. We have learned certain things from medical professionals, such as put your pills in coffee grinds before disposing of them,
Right.
stuff like that. So
Yeah.
are we trying to create classes where we teach these seniors or these parents and these folks who got medications how to dispose of the leftover medications?
Yeah, I've been to the senior center, I've been here as well as over in Henderson, and did just that. I taught them about Narcan, but we also discussed how to safely dispose and safely store their medications so they're not available for misuse. But just about every police department and the sheriff's office and even some pharmacies have drop boxes for pills. So you just want to take a Sharpie and just scratch out your personal information, and you can just put it in the drop box.
Okay.
Yeah. Yeah, and Granville Advanced Public Health has a little pamphlet that when we table and exhibit, we have that and distribute that to educate people about that.
Yeah, I think the information you just gave about the police department and the fire department having these drop boxes, a lot of people don't know about it.
Right.
So is there maybe a thing that we can do of possibly dropping off that information at our local clinics? So then when our doctors prescribe, they also give them a little paper that says, whenever you're done with your prescription, these are your options.
That's a great idea, Commissioner. That's a really good idea. In addition, twice a year, the DEA hosts a drug take-back day, and that's actually coming up toward the end of April. And I know the Granville Sheriff's Department is involved in that. I believe they're having an event up at the Walmart here in Oxford. And it's an awareness around, safely disposing of medications, just over the counter as well as prescription drugs. But we do have at least our brochure in doctors' offices, and we try to make it available when we're tabling. But I think on a regular practice to ask physicians to mention when you're done, please dispose safely, take it to the drop box. Yeah, good suggestion. Any other?
Yeah, it's probably easier said than done. But what I have found is people who have drug problems go back to the same environment where they started on drugs. Even if they go to jail, they go back to their community.
Right.
They don't have a place to go, a physical building
That's right.
where they can get counseling and treatment. They go right back to their neighborhoods. I've had 4 clients who were incarcerated for a little while, and as soon as they got out, just like you said, their bodies weren't used to that same dosage of drugs, and they overdosed. They have no place to go.
Right.
Judges don't have places to send people. People can say what they want to say, but if you go back to that same environment, them same folks, you're going to use drugs again.
You're talking my language. I look around and I see all these vacant buildings. I look across the street and there is an old county jail sitting vacant. I mean, wouldn't it be great if we could turn that into recovery housing, transition housing, right? Yeah, no, I'm right with you there. Yeah, yes.
Just a quick question. You mentioned you were interested more in preventative strategies. What's the top 1 or 2 that you interested?
Education. I mean, I've been talking to school counselors and school social workers, middle school, high school. There is not consistent evidence-based substance use curriculum being offered in the Granville schools.
Oh.
And not only is it to kids, but we need to outreach to parents. In Vermont and Connecticut, where I worked before, we surveyed our youth every 2 years. And because we did that, it was, and we asked questions around mental health and substance use. We qualified for, it's now a CDC grant called the Drug Free Communities Grant, $125,000 per year for 5 years, focusing on youth prevention of substances and mental health. We don't even qualify. Granville doesn't even qualify or eligible for that grant because we don't collect the data. So we need to collect data. And I'm meeting with the Youth Leadership Council Thursday night to see if I can get them, because if we could make this youth-led, I think our chances of surveying we might get a more positive result. But without data, I mean, we have no benchmark data on our youth right now because we don't collect the data. So if we could make small steps, take some small strides, and maybe we just start with, there are just 4 core questions, which include a total of like 16 data points. If we just started there, that's a start.
And are you looking at charter schools and whatnot
Yep.
as well? Okay.
Yep. Everybody, because this is countywide.
Okay, just check.
Yes. Yeah, no. So I just met with Oxford Prep today, and they do some health, but I don't know to what degree. I need to talk to these PE teachers and find out what exactly they're using as a curriculum. So, yeah.
One thing I noticed, my daughter's 20, and when she was in middle school, I asked her what percentage of the kids smoked weed. She said at least 60%, maybe a little bit higher. And the way she said it was so cavalier. I'm looking at her like, okay, neither one of your parents do drugs. Your aunts, your brother, your uncle, none of your cousins, your first cousins anyway. And I'm like, where did you get this cavalier attitude towards drug usage? And are you using drugs? And so she said, Dad, everybody does it. She said, it's common. Like it's just as common as them eating candy. And so I'm like, well, where do they get, how does an 8th grader get weed, or a 6th grader or 7th grader get weed? It's like their parents. So now I'm appalled. I'm like, you gotta be kidding me. But growing up in the 80s, there was say no to drugs. That was my dad. That wasn't, and my granddad. That wasn't Nancy Reagan. But at least there were programs. There was DARE when I was in high school. But when you say youth and education, one thing I feel that we definitely need to do is focus and show them, because I wonder, we've all in our generation have seen people that were addicted to opioids in the 80s. And so we saw them in the 90s, we saw them in the 2000s if they survived. And you still have people trying heroin for the first time. You still have people trying fentanyl for the first time. And it's like, okay, something's wrong. Something's broken with our system, because when you see the end result, you know what the train wreck is at the end of the day. And we still have human beings willing to try these substances. So definitely, I think, and it's not a scare tactic, but we really need to show our youth, like, this is the road and this is the end of the road. And we have to keep that in front of them as much as we can, because something has definitely happened in the last 25 to 30 years that has made our society a lot more, what's the word I want to use, accepting of drug usage. And as we pass these laws that allow people to do drugs openly, I was in DC. I'm gonna shut up. I was in DC on July 4th, the day that they made smoking weed legal in Washington, DC. Every 5 steps I took, I smelled marijuana. And I'm like,
Yep.
okay, is this what's gonna happen if it ever comes to North Carolina? And so I have friends that live in states where it's legal. And when you visit there, your nose definitely smells. Las Vegas, it's like they're like cigarettes. Like they just smoke weed on the streets naturally. So it's like this is where we're going as a society. So definitely, I would appreciate if we could do more and get to the schools. And we may have to start at the elementary level,
Absolutely.
not at the middle school
Oh,
level.
no, we have to start at elementary. And unfortunately, because I did ask this of the Association of County Commissioners, can we apply opioid settlement money to marijuana education? Because we know it's a precursor to, harder stuff. But although today's marijuana is nothing like the marijuana when I was a teenager, it's so much more potent today.
Right.
So much more potent. And legal or not, it's here. I mean, it's everywhere. Consistently, I've heard from school counselors, parents are smoking in the car when they drop off their kids. The kids come into school reeking of weed. Some kids have had to go home, get their clothes changed. I've heard 2 stories of youth who fell asleep in class because of secondhand marijuana use, secondhand from their parents' use. They're getting it from parents, they're getting it from siblings. I heard a story today that a very enterprising young student had a business selling marijuana vapes and had a whole warehouse practically of these things. But we do need to start young. We need to, it's a family, it's not just kids. We need to educate parents as well. They need to be aware of what they can do, because parents are the number one influencer on their kids. They really are. And what kids see from their parents, what kids see how their parents handling stress. Oh, I'll just have this glass of wine to relax. Well, what kind of message are you sending, right? They're smoking weed. Oh, it's natural. It's not a big deal. It's just weed. Well, it's not just weed. The potency, and studies have shown this, the stronger the potency, the more frequent the use, you can now do permanent brain damage from smoking weed. Permanent. Recovery is possible, but it's a lot harder, right? So there's so much we need to do. And I think that's a good segue, if I may, to bring Dr. Eric Morse to the podium, because he has, I think, one solution that we would really like to make available for Oxford that would go a long way.
His is the next one. He's going to bring your slide up.
Oh, thanks. So I'm Eric Morse. I'm an addiction psychiatrist. And I actually am trained to do the work that I do from the University of Maryland. And what I have been doing for 24 years is treating opioid use disorder. That's my passion. And I got my start in Maryland, moved to Raleigh in 2006 and worked for Southlight. And at that time, Southlight is in Raleigh, and we were having people drive, 1.5 hours one way to the clinic on a daily basis to get treatment. And I went to the CEO at the time and said, we need to open more clinics. And he said, Eric, that's not our business plan. So I made it my business plan. So I opened Clayton in 2010, Henderson in 2013, and then North Raleigh, Siler City, Zebulon, Dunn, Roanoke Rapids, Asheboro, then Durham. And it takes a while for me to open a clinic. And it takes a good amount of money and upfit to open a clinic. And then you also have to have it inspected, which takes forever. And recently the regulations changed. The federal and state regulations changed, allowing for mobile units. So I opened the first mobile unit from the Morse Clinic in North Raleigh to Healing Transitions, both the men's and the women's campuses. And according to Mission Mobile, who designs and builds these units, is the #1 provider nationally. And they're based out of Kernersville. And I like supporting North Carolina businesses. We are the largest, fastest growing mobile unit in our nation's history. So we have about 100. We started on July 7th, and we already have about 112 patients. And I've done the vast majority of the admissions myself on the unit. With post-Helene recovery funds, the state granted, I think it was $2.4 million to VIA, which has a lot of the western part of the state. And they decided to spend that money on 6 mobile units. And I applied and I got one of the 6. So they bought me a mobile unit, just like the one you see right here. And they designed it, they built it. They're very fast. They can get it done in about 120 days. And it is currently parked with a barbed wire fancy gate behind Vance Recovery in Henderson, North Carolina. I can't find a place to park it, and that's why I'm here. I've looked in Oxford. I want to come to Oxford. And everybody thinks it's a fantastic idea. They know that fentanyl is a huge problem, a huge killer. Everybody thinks it's a great idea, but nobody wants to park it near them. It's a great idea. I was talking to someone. They said, I didn't think I was a NIMBY person. Not in my backyard. But I guess I'm a NIMBY person. I don't want to be a NIMBY person, but I'm a NIMBY person. And I said, you don't have to be a NIMBY person. You can let me park in your parking spaces. And we're talking about from 6:30 to 8:30 a.m. and she opened at 9. So I'm like, why won't you let us park here? So that's been my experience. So I'm here to ask for your advice on where I could find a place to park. What we need is a flat surface, and we need a RV outlet plug. So we need just and we'll pay for running the wire and setting up the plug. I think VIA actually have given us funds for that. We just need a place to park. So if y'all have any suggestions, any advice as to where we can park and help people, we're ready to go. We just We have the staff, we have the unit, we have the medicine. We just need to find a place to park. Yes.
I point thinking we're both talking your areas names. It's neat, and I think the Granville Homeless Coalition be happy to have you here. We'd like to get together with you and probably tour
Yeah,
city, look at different sites, and see what we can work out.
that'd be wonderful.
Okay? So
Thursday.
Is contact.
Oh, yeah,
we'll get Mrs. Hanson and set up a date.
sounds good.
Yeah,
Okay,
I think-
We can
I
come
think
back
we
and
can come up with something.
tour. Yeah.
His email, so.
Okay.
Good.
Good, good.
Great. Thank you.
I didn't realize it would be that easy. So I just feel,
You see, here in the city, we know we have some issues, especially homeless, and we
Yeah.
try to confront and face it.
yeah,
We don't deny it.
yeah,
So I know you work with the Granville Coalition as we meet
right,
monthly. Yeah, we just had a meeting yesterday. But
Yeah.
we need to resolve this issue, and by denying it and
Yeah.
not facing it,
Right.
we're not gonna go anywhere.
Yeah.
So
And-
this board is committed
thank you, thank you,
100% to working in this
thank you,
towards this issue. Not just the board, my
right,
staff is, because I learned this
thank you,
these issues from the fire chief when I first took office, fire chief back in 2023 when we started having to get people at night. So I know there's an issue.
and we know that there is a high percentage of those who are unhoused who have a substance use disorder, and we need to make treatment more accessible, right? And when it's more accessible, it's more likely that they're going to continue treatment and we can save a life.
We'll figure something out. Dr. Morse, about how many parking spaces do you think your RV takes?
Yeah, the RV takes about 3 standard spots. And depending on, I would say the patients, some of them have cars. And so probably 7 or 8 more spots. So I would guess about 10 spots, standard spots would be good.
Do you need one stationary location or could you do different locations
That's the
around the
best
city?
place.
Yeah, we can do more than one location. There's no limit. But usually when we park for at least 2 hours because that's how long all the paperwork takes to start a new patient. There's a ton of consents and we have to make sure you understand everything that you're signing. And it just takes a good amount of time. So I don't know of any mobile units that are doing more than 3 stops.
You could do like Mondays and Wednesdays at one location and Tuesdays and.
That is possible. I mean, methadone, especially early on in treatment, you do want to see them daily. Those first 2 weeks or so. So there are some out west that are doing Monday, Wednesday, Friday at one location, and then Tuesday, Thursday, Saturday at another location, and they're really spread out far apart, and they give you a take home with the same dose that you got that day. So that is a possibility, but I think that for higher quality of care, our preference would be to be there Monday through Friday, and then on Friday we give them Saturday and Sunday take homes.
Okay, we'll definitely
Yeah,
Probably
we can-
started
we can
more.
do that, yeah.
try to get a meeting with you,
Excellent.
has it? And we can work this out. I'm quite sure we can.
Thank you.
And thank you both for your presentation.
Appreciate it,
Thank you.
appreciate it. Thank you for the work you're doing.
Thank you.
Get that right.
City business, consider appointing Marley Spencer to the Tourism Development Authority. You need a motion.
A motion?
Motion by
Mark
Commissioner
Spencer.
Toby. Do I have a second? I'll second. Second by Commissioner Bellis. Any discussion?
All in favor?
Aye.
Any opposed? Motion carries to appoint Marty Spencer after the short name, to the Tourism Board Authority.
On to the regular board meeting. We've got our regular stuff, prayer by Tedra Smith from St. Cyprian's, Pledge of Allegiance by Scotty Brooks, proclamation for JF Webb athlete. I still haven't heard. He won the state track. And I still have not got his information, just so you know.
I'll make it my business go down there tomorrow.
Presentation on an update from the Granville County Schools by Dr. Stan Wimborne. We will have a proclamation honoring the late Reverend Jesse Jackson. Then we will have public comment, public hearing, and city business. 4.1, we will hold a public hearing to receive citizen input regarding a request by North Point Development for a conditional rezoning of 85 plus or minus acres located on the outer loop backing up to Horner Siding Road. The requested zoning is GR5CD. Consider approving, 4.2, consider approving the conditional rezoning of 85 plus or minus acres for the outer loop backing up to Horner Siding Road. Planning Board recommends approving this rezoning request. 4.3, we will hold a public hearing to receive citizen input regarding the non-contiguous annexation of the same 85 plus or minus acres located on the outer loop backing up to Horner Siding Road. 4.4, we will consider adopting the non-contiguous annexation ordinance of the 85 plus or minus acres. Staff recommends adopting the annexation ordinance. 4.5, we will consider adding speed cushions on Old Baker Street, Oxford Park Boulevard, and Polly Drive. The joint committees of the Public Works and Planning, Business, and Community Committees recommend adding those speed cushions. 4.6, consider approving the attached resolution of intent to change the city charter. This would be changing the mayoral term from 2 to 4 years, beginning with the November 2027 election. And we call for, there'll be a vote on that. I'm sorry, I don't have that, so I need to add a vote to that.
Can we add public comment for that? Should we do it?
There is.
In the public hearing.
It's in the public hearing.
Yes.
4.7, we will call for a public hearing for the April 14th board meeting to receive citizen input on the change to the city charter. That's where they'll go to.
Thank you.
But we have to do the resolution of intent first.
Thank
4.8, consider adopting the resolution authorizing the city manager to enter into a contract with Harper General Contractors to rehab the clarifiers at the wastewater treatment. Staff recommends adopting the resolution. After that, there's simply the consent agenda, which would approve the financial report for December 2025 and January 2026, and the minutes from February 2nd and February 10th. And that would be it, sir.
Before we adjourn from mine, I'd like to get someone entertain a motion. First, go to closed session on North Carolina General Statute 143-318.11. And it's basically considered qualification, competence, performance, condition, appointment of public officer, employee, prospective public officer, employee. Do I have a motion?
Motion.
Second.
Motion by Commissioner Bellis, second by Mayor Pro Tem Toby. Any discussion? All in favor?
Aye.
Any opposed? Motion carries. This time we'll adjourn to closed session. Thank you.